All right, thank you all so much for joining us this afternoon for our Policy Hot Topics Forum by the title, Health Equity at the Crossroads. We have an illustrious panel of diverse policy stakeholders in several capacities that are being moderated by a tremendous policy stakeholder and policy champion in his own right. At this point in time, I would like to introduce our moderator for today's forum, Mr. Daniel Dawes. I would also like to invite you to be a part of this forum. This is an interactive forum, so we will be taking questions from the audience. I will prompt those questions, and we will get to as many questions as possible. We also invite you to engage in what we call our Twitter wall, okay? So this is an important cap to our discussion. This is an opportunity for us to have some critical dialogue and touch upon some of the topics that have come up during our breakout sessions and our opening plenary session. At this time, I would like to welcome Mr. Daniel Dawes.
Thank you very much, Dr. Hopkins, and welcome to everyone. So I would think that a lot of you would be sick and tired of talking about politics and the political determinants of health. So it shows me you really care about this and you understand the implications for health equity moving forward. I am very excited about this part 2 of a series that we've been hosting on policy dilemmas or windows of opportunity. We had the first forum a few months ago talking about the right to health equity. And in that first forum, we talked about the historical aspects of the ACA, and we explored the strengths and vulnerabilities of the Affordable Care Act, right? The big elephant in the room, using an equity lens. So today, we're going to really look at this issue and actually expand upon that by addressing some other implications, some other policy issues that we're currently faced with and will be facing soon. So without further ado, I really want to introduce our distinguished panel, who I know very well. I know many of you do as well, and have been incredible champions for health equity. So our first distinguished panelist is the Honorable Pat Gardner. Many of you know she is our representative in the Georgia Assembly. Yes, come on, let's give her a round of applause. She's one of the few health policymakers that I can say without a doubt knows the impact that social determinants of health has on our ability to advance health equity. And what we wanted to do was to bring on someone who is making policy, someone who is actually implementing policy, and someone who is using science to inform policy. So let me begin by introducing our first distinguished panelist, Pat Gardner. As you heard, she's someone that is near and dear to my heart. I school with us when I got here to Atlanta. She welcomed me with open arms. She introduced me and mentored me, helped me to understand how the legislature works here in our state and how to push and pull the appropriate levers to advance policy that would positively impact the communities that we care deeply about. So she represents our district. She's been a representative for 16 years. She is a proud wife, mother, and grandmother. She's been a former teacher, woman. But most of all, she's been a consistent, reliable, and solution-oriented leader. Serves on all of the committees, basically, for the most part, that tackle the social determinants of health. So from appropriations to transportation, higher education, natural resources and the environment, and the Appropriations Committee, Health Subcommittee, which is a multi-billion-dollar subcommittee that has jurisdiction over Medicaid. So very, very pleased to have her with us. And just to give you an idea of some of the work that she's been involved in, Secretary of the House Minority Caucus, Chair of the Study Committee on Mental Health for the Fulton County delegation. She is a huge behavioral health champion. Do I have any behavioral health champions in the auditorium? Yes? Good. So this is your champion. And she has not only been a mentor to me, but she's also been a mentor to many of our students, our fellows, and our residents. And in fact, she actually mentored our other two distinguished panelists, who you're going to learn about momentarily. So let's give Pat Gardner another round of applause. Then it is my pleasure and honor to introduce Chanel McGoy, Dr. McGoy, who is the Director of HIV/STD at the Tennessee Department of Health, and she oversees a state federal investment of resources that supports a comprehensive HIV/STD service delivery system. So she's looking at surveillance issues, prevention, care, treatment, housing, contracts, et cetera, in Tennessee. And not only is she the director of that major entity in Tennessee, but she's actually one of our proud, as you heard me say, Satchel Health Leadership Fellows. And she actually, yes, woo! She was in the first cohort, so she's really special to me because she was part of the first cohort of fellows that I got to meet when I got here, and was extremely impressed with their brilliance and thoughtfulness when it comes to these issues. So she actually, not only is she a fellow, but she serves as the vice chair for the Southern AIDS Coalition for SAC, and she is chair-elect of NASTAD, the National Alliance of State and Territorial AIDS Directors. So she's just chair-elect for 2 more weeks, then she will be the full chair. So we are looking forward to working with her to address the HIV/AIDS related health disparities in our system. So let's welcome Dr. McGoy, please. And then our third distinguished panelist is Carmen Dickinson Copeland. She is a biomedical scientist with 6+ years of training and experience in clinical and basic sciences. And we are very proud of her because she not only is a fellow, current fellow in the Satchel Health Leadership Institute, but she received her master's and doctorate degrees from our institution, from Morehouse School of Medicine. So another plus for Carmen, for Dr. Dickinson. And just to give you an idea of some of the research she's been involved in, working on severe malaria pathogenesis. She's worked with the University of Ghana. She's done remarkable work nationally and internationally, and she is recognized for her scientific accomplishments. She's actually given 5 scientific presentations in peer-reviewed journals, 18 presentations at national and international meetings, and has received some distinguished awards such as the Young Investigator Award from the American Society of Tropical Medicine and Hygiene, and the Robert D. Watkins Graduate Research Fellowship from the American Society for Microbiology. And she actually uses her work to impact health equity beyond molecular science, and looking at the gap between biomedical science and health policy research. So she's really a triple threat. You talk about biomedical science, clinical research, and policy, that's outstanding. So welcome, let us welcome Dr. Dickinson Copeland. So what I thought I would do is to start out by asking this general question. So we talked about policy dilemmas or windows of opportunity. Wanted to build upon that and do this open-ended question. So wanted to ask you guys, what are the policy dilemmas that have emerged recently? For example, we know the Affordable Care Act, right, and issues impacting that with repeal efforts, or the budget, budget cuts. So let's talk about those and opportunities that we can leverage. I'm going to start with you, Representative Gardner.
Well, thank you very much for having me here. It's always fun as a policymaker or hopeful policymaker to be among the people who really know about health policy. And I can say certainly from Daniel and from many people in this room, I've learned a lot about health policy. It is a dreary day in many respects, but it is step one in a very long process. We know that the Republican plan for creating something that we could call Trump care passed barely, but it did pass the House today. And Daniel asked me to speak a little bit about the process that it would go through next, as well as some specifics about how I think it will impact on Georgia's health system, assuming we have such a thing as a system. So from basic civics that a bill passes the House. Can you hear me? It's on?
Yeah, now we can just talk.
Better? I just need to get closer.
There, I do hear myself now. Thank you, sorry.
Talk a little bit about the process
That it will need to go through, and then tell you a little bit about what I think the impact on Georgia will be. Basic civics, a bill passes the House. It then goes to the Senate. We certainly expect the Senate to make some dramatic changes. If they choose to pass something, it will then have to go back to the House. The House will say, we don't agree. The Senate will then insist on its position, likely. I mean, assuming that all of this keeps moving forward, which there seems to be a big push for something to happen. And then a conference committee will be appointed, including both senators and House members. And they come up with a plan that then has to go through all these steps again. Not just passing the House as it did today, but it has to go through the committees, it has to go through the Rules Committee before it even gets to the floor, which is of course what happened today, barely. So as you know, Georgia is a state with a very high level of poverty. We have one of the lowest funded Medicaid programs in the nation. As an example, if Georgia's average recipient is in the range of $2,400 per person, and there are several million people in our Medicaid program, it is a big program for children. The national average is more like $3,600, and don't use my statistics because I leave the statistics to these folks to tell you. But if one of the things that they're thinking about doing in Washington is punting back to the states to make the decisions, and they have decided that they're going to give the amount of money that was currently being used in that state's program, and Georgia already has one of the poorest funded programs in the nation, you can see how Georgia will be hurt in some ways that is really worse than many other states. Who will suffer? I think we all know. First thing that happens is they reduce what they pay the providers. Providers drop out of the system, people can't get health care. It's abysmal way to think about it. I mean, if you have already a lean program and you're funded at a lower level than other states, are they going to do something to compensate for the fact that we have benefits not to expand Medicaid? I mean, we all know we've been paying for Medicaid for people in Michigan and other states. Our taxes have not gone down because we haven't expanded Medicaid. So it is a huge problem. We didn't talk about some of the specifics because I'm sure they'll change, but
let's talk about that then. Because
Okay.
I'd love to get, especially Chanel's input as well as yours, Representative.
Okay.
So we know that the House just voted 217 to 213, very close vote, on this repeal bill. But in the bill, there are key elements, right? Just want to go through them quickly if you don't mind. Is that okay?
I hate for you to call it a repeal bill. That's just a slogan.
Just a slogan, so I'm using their language.
It is a slogan that
So what would you call it?
well, it's not replace and repeal, we know that.
Right. Okay, that's one thing, okay. I won't echo that, but I hear you. So in the bill then, here's what they're targeting, right? We know it's not going to undermine the entire Affordable Care Act. They're going to leave in the delivery and payment system reforms. They're leaving the other pieces tied to comparative effectiveness research, et cetera. But there are insurance reforms that, are in this bill that I'd love to get your thoughts about in terms of how it would impact our ability to advance health equity. So it ends the tax penalty against people without coverage, okay? It ends Medicaid expansion funding. We know about it, so does that really hurt us then if they do so? Changes Medicaid from an open-ended program to one that gives states fixed amounts of money per person. Replaces the ACA's cost-sharing subsidies based mostly on consumers' incomes and premium costs with tax credits that grow with age. Okay, so we're no longer looking at your income status. We're looking at basically age and giving you a flat credit across the board there. And then it repeals taxes on the wealthy, on the insurance companies, the drug and medical device makers. It also has a 30% surcharge for those who allow their coverage to lapse. So if you allow it to lapse in 63 days and you don't get coverage, then they'll up your premiums when you do apply for coverage next time, 30% or more. Then there's this piece about state waivers would allow insurers to charge older customers higher premiums by as much as they'd like. States get $8 billion over the years to finance these high-risk pools that cover those with pre-existing conditions. And states would also get $130 billion to help people afford coverage. And then it says the ACA provisions, it would keep the ACA provisions that would allow dependents to stay on their parents' coverage up to the age of 26. So when you hear those specific pieces, right, very narrowly tailored, is that cause for worry then still? I mean, how does it impact our ability to advance health equity, especially for vulnerable populations? So thoughts?
Yeah, no, I think what it does is it gives to a governor some options that can't possibly work. I mean, they're punting. Whoever thought we'd be talking about whether it was important to have pre-existing conditions covered in health insurance? I never thought we'd go back there. I mean, it's an outrage. Well, they're saying they didn't do it. They're allowing the states to do it. So in a very conservative state like ours, what do you expect? I'm told by some people who work in the governor's office that this plan is so unworkable that they are not going to set up a high-risk pool that might be funded for a couple of years and then run out of money. So,
Well, that's pretty hopeful then.
I think the hopeful part, and we keep looking for our bright spots, is that there's a long road ahead for this legislation. It's pretty clear after 62 votes that the House was a little bit tired of talking about repeal and replace, their slogan. They finally passed it so that they could punt it to the Senate. And at this point, it really has put some pressure on state governments that are untenable from my point of view. So I hope that the governors, particularly the Republican governors, are going to scream loudly. And we're going to talk a lot about advocacy later, but this is a time people are learning about health care. They care. Anger is a great motivator, as most of you know, and we need, as advocates, to make sure that they stay active and don't get worn down by the process, because it's really easy for that to happen. Yeah, I really want to hear from some of the experts here, but this is really important, obviously, to me.
Absolutely. So Dr. Midori?
Sure. What we know is that Medicaid is the largest source of coverage for people living with HIV in our country. And so it provides coverage for about 40% of the people living with HIV around our country. So there's a recent analysis that showed that the increase in Medicaid coverage in expansion states also drove a nationwide increase in coverage for people living with HIV. So Tennessee is a state that did not expand, but we know that there are 32 other states as well as DC who did. So we are concerned about what that could do for people living with HIV and the coverage that they have.
And how many folks living with HIV and AIDS live in your state?
We have about 17,000 people,
And how many
close
of
to
them
18,000.
actually have coverage through the exchange or through Medicaid and would actually benefit from Medicaid expansion? I'd be curious.
Yeah, so that's a question. I don't have the answer to how many people, but we, I think there are about 7,000 people who are covered under Medicaid. And then we also have Ryan White, which is the payer of last resort for people living with HIV. But we do also know that the recent proposals removes important protections that have prevented insurance companies from discriminating against people living with HIV. It makes it more expensive for them to have coverage and treatment, and so those are things that we're concerned about as we try to move forward in getting to zero and eliminating HIV in our country.
Thank you. So it sounds to me that those pieces that would actually, I guess when you talk about the cost-sharing subsidies and the premium subsidies, when you talk about giving tax credits versus the subsidies based on your age, that we would be creating this separate and unequal system then that would actually cause those who are sicker and older more costly coverage. It might even be out of reach for many of them because of a pre-existing condition.
Right, pre-existing.
Essentially. Okay, gotcha. So let me actually ask this one then. So we're talking about health policy. how does health policy take shape in the midst of leadership transitions, right? What policy dilemmas emerge which must be addressed, and what salient windows of opportunities are we afforded within a change of leadership? So I know, don't want to be Debbie Down, or we want to see the glasses half full.
Right.
I'd love to hear your perspective on that.
Sure. Some of the dilemmas that we're concerned about in the work that I do are policies that discriminate or create barriers and challenges for our LGBT community. So, for example, some of the religious freedom policies that were introduced in federal as well as state that gives people the ability to refuse to provide services or marry persons based on their sincere religious beliefs. So,
And we know that the president just signed such an executive order today.
yes.
Got you.
Yes. And when you're talking about a vulnerable or marginalized population, so yes, to begin with, so someone who's living with HIV and AIDS or who may experience stigma based on sexual orientation or even race, there's this multiplicative effect of discrimination that they experience. And so with policies that are put in place to even further marginalize them can create barriers in them accessing healthcare.
Thank you. So how about you, Dr. Dickinson, hopefully? Any thoughts?
Well, not wanting to focus on the negative aspects of what this could mean for us, but, you know, as someone who looks at the health policy and health equity space, it definitely does create more barriers that allow this system of inequity to persist, making those gaps larger between the haves and the have-nots, and making the ability to obtain health equity practically impossible for those who are in poverty, those who are the isms, right? We're back to the isms again. And so it's very regressive. And I think that's the biggest dilemma. But on the other side, I think that has been the recognition of the importance of science in really informing health policy. Politicians, no offense, but politicians have been the ones who've made these pieces of legislation, right? And what we know is that by and large, they're not health scientists. They're not epidemiologists. They're not the people who really understand the ramifications of these decisions. And so true. Because their bottom line is a fiscal, you know, it's a fiscal responsibility and not a human responsibility. That's something that particularly scientists that work in clinical research, we can't forget the human aspect of what it is that we do. And so it actually allows, I feel, the public to really get an opportunity to appreciate science, take us out of our ivory towers, if you will, and particularly with the Science March. I mean, you had all these really smart people who don't normally engage in political discourse, who took to the streets, you know, by the thousands. And I think that that is changing the message for this country, so, and placing the emphasis on science.
Appreciate that. So I'd actually love that, to piggyback on that and ask Representative Gardner, you know, you mentioned using science to inform and getting more active. We talked earlier about going to a discussion on advocacy, and as scientists and as a policymaker, how can they get involved?
at this level, at the grassroots level, to inform policy or to help you as a policymaker and help your colleagues?
Well,
What would be most
setting
effective?
aside the insurance system that we're talking about that has been pretty dismal for most of us today, if you think about what science has already given us, I mean, we look at progress that has been made with HIV, for example, and we look at how advocates are learning from the scientists, not necessarily the legislators. We don't respond until we hear from our constituents. So as you as scientists help the advocacy groups move, I mean, I think HIV is a good example. I'm wearing purple today, and it's not because I always wear purple, but I have a friend in the audience who has been a wonderful citizen advocate for epilepsy. And she makes sure that I wear purple for all important occasions. Isn't that true, Brenda? Thank you. And I've spent a lot of time this year working with some public health advocates about cervical cancer. I mean, we now know, thanks to science, that there is a vaccine that prevents cervical cancer. Well, in California, my granddaughter, I said, well, is she going to have the vaccine? And her mother said, oh, yes, we have to sign a release if we decide not to do that. Well, in Georgia, we're way under 40% of young women and men who have actually had the vaccine, which is just crazy. I mean, I don't understand it, but it is. I mean, we think cervical cancer has to do with sex, and we can't talk about that, right? So when I brought it up that we should increase the educational process in the elementary schools, they said, oh, no, we can't talk about sex. So we didn't get very far with that, but we do have a major initiative through the health departments to begin educating pediatricians and health departments. But I say all this just to really talk about what has happened when people are starting to learn about how healthcare works, as they look at the changes that have been proposed and how it will impact on them. They really are starting to care. And if we can keep that energy going through a next election and throw out some of the people in that Freedom Caucus who think it's all about money. It is not about balancing a responsible system with the best that we can do for human well-being.
Are there groups then that perhaps folks can, because we did I believe a panel a few months ago where, folks had asked, well, as a scientist, how do I get involved? I don't even know where to begin. And we talked about, well, there's so many associations who do incredible advocacy work. Can you give us maybe some insight into perhaps some particular groups or things that they can do then?
I loved the name of Carmen's class,
Yes.
the Fierce Fighters.
Fierce fighters.
I mean, we need fierce fighters to be helping in these organizations, and they tend to be organizations with a narrow focus. One of the places that I think we as a nation have really made some mistakes has to do with how we have allowed our reapportionment process to go forward. I mean, the people that draw the maps, we know gerrymandering is not illegal. Both the Democrats and the Republicans have abused the process. The Voting Rights Act brought some sanity to the representation of minorities. But what we're facing in almost every state are maps that have been drawn so that there are very few elections that are competitive in a general election anymore. You know that all the elections occur in the primary. And who wins in the primary? Often the most extreme candidates. So I didn't know if that's where you wanted me to go, but I do believe that we need to look at some of the structures of our democracy to make sure that there's adequate representation. And Georgia is the perfect example. We have 180 House members. There were 6 seats where either a Democrat or a Republican could have been elected.
all the other seats were determined in a primary. I don't think that reflects our state. And we ended up with 120 Republicans and 60 Democrats. I don't think that reflects the balance of our state. So that's one way, but I think getting involved with the Mental Health Association does wonderful work. The Diabetes Association is very active in our state. The cancer, I mean, there's going to be a new cervical cancer coalition developing. So I think to go focus on, I hate to say the disease of the month, but you know, this year is the year about the autism spectrum.
That's right.
And we know we're terribly behind, not just in diagnosis, but in having available treatment in our state. So when these get on people's radar, and it's not just Democrats who have children on the autism spectrum, things start to change. So it's that involvement, and maybe you have to run for office one day.
I think there's also a lot that can be learned from HIV activists in the late 80s, early 90s, and the work that they've done to secure funding for programs like Ryan White for care and treatment, as well as state-based advocacy groups that currently exist. In Tennessee, we have the Tennessee AIDS Advocacy Network, and each February, they're at the Capitol talking to legislators in our state, stressing to them the importance of funding for care and treatment and prevention dollars. And then, you know, regionally, the Southern AIDS Coalition is another advocacy group that works hard to address HIV and AIDS and make sure it looks at proposals that come across regarding, you know, care and treatment and the cost for medications. So learning from those examples and being activists and advocates, as well as putting pressure on the science to move forward. We've gone from taking many pills a day for people who are living with HIV and AIDS and reducing those numbers so that the burden of taking the medications and staying adherent to them isn't as great as it was in those early days, as well as those biomedical interventions such as PrEP, pre-exposure prophylaxis. It's a pill that someone who's negative can take to prevent them from getting HIV on a daily basis. So, you know, the science is so important, and then working with communities to get those messages out, translating the science into practice is essential.
I want to underscore that, is getting that science to us in an understandable.
That's exactly the point I wanted to make. Before we go to questions, I know Dr. Hopkins wants us to take questions from the audience. I just wanted to say that, again, looking at the way that the discourse was changed around HIV, one problem with moving the science forward isn't that scientists aren't interested in moving the science forward, but quite often there's not a lot of support financially. Funding is always an issue when you're a scientist, so to speak, particularly a biomedical scientist, because you have to convince people, first of all, that the science that you want to do is going to be useful for their community. And if you're not able to do that, then you don't have the community lobbying for legislation to increase funding for science. And so what we have is a lot of scientists who are doing the same thing over and over again, right? And they're not pushing the needle because they're afraid that if they push the needle, then they'll lose that science funding. And it's a vicious cycle because it means that we don't move forward as far as public health, as far as biomedical research. And the result of that is, you know, is what we have now, which is a disinterest in science. So that's all I wanted to.
Well, and I appreciate that. So I actually want to give kudos to the HIV and AIDS advocacy groups and the behavioral health groups, because I will tell you that early on when we were trying very hard to push for health equity, a robust health equity agenda in the Affordable Care Act, you know, it was the HIV and AIDS advocacy groups that first said, you know what, we can tackle HIV/AIDS related disparities. I don't know if you remember the first HIV/AIDS strategy. And they pushed us to say, as we were developing the ACA, to say you should require that these other strategies around quality and prevention and health literacy also tackle the underlying disparities, right? So behavioral health actually was the first group that said, you know what, we can actually take this health reform negotiation and we can infuse a health equity agenda in there. So kudos to the behavioral health groups and kudos to HIV and AIDS groups and other groups as well that are in the room for that. So I'm going to open it up now to audience questions. I know we have about 20 minutes left. I'd love to open it up. I'm sure you're just dying to ask a question of our distinguished panelists. Who would like to be first?
Actually, I think I'm going to start.
You wanna
since
be,
I have the mic. And I'm just going to do a quick little housekeeping. Daniel, go ahead and move up your mic a little bit so we can catch you more. Yeah, just get up as high as you can. There was one point that you made that's particularly salient for those of us that are supported by
when it comes to translating the knowledge. As a community, I consider myself a community health researcher and a health research administrator here at Morehouse School of Medicine. It's vitally important that we figure out the best ways to translate that knowledge. I think those of us that are in the scientific community are very comfortable with what gets you kind of the most, what holds currency in our position, which are peer reviewed publications and scholarly output. From your vantage point and your experience, are there any
other types of ways that science has been translated that has made an impact or has helped to inform your stance or inform your work in your various capacities? If you can think about that.
Great question. Who wants to take that first?
I will. Oh, no, go ahead. Oh, okay. Well, I think that one of the situations that I found myself in as a basic scientist, for those of you who don't know, most of my time was spent in a dark lab with no windows, and pipetting a lot of things, right? Measuring a lot of things, and not really being in touch with the populations that I was trying to help. And so for me, the opportunity to actually work in the communities in West Africa that were being hit most hard by the most deadly form of malaria was what actually motivated me to move forward, motivated me to stay in that field, even on the nights when I was in the lab until 3 or 4 a.m. But it was having those dialogues with individuals and recognizing, first of all, that malaria is a disease like the flu. So when you're in an endemic area, you get malaria 3-4 times a year. You go to the pharmacy, you grab something. And so trying to understand how I have a discussion with someone around a life-threatening disease and what they felt was most important for me to focus my research on. What aspects of that disease did they feel like would translate into the most meaningful results for them? And so it kept me grounded in the idea that what I was doing wasn't just basic science, it was a public health service. It was me engaging the public, finding out what I could do to be useful to the public, and making sure that my research was always focused around that. And then the findings that I had, because I knew that the majority of times my publications wouldn't make it into a rural village in Ghana. It was me taking the opportunity to have those conversations and relay what I had done so that they could feel like I was part of that community and not working to help fix that community.
And I think that public health has an important role in
Implementing the findings, using the research and the publications to inform the interventions that we do, and to inform where we should direct our funds to prevent diseases, and then to address treatment and cures.
Dissemination is difficult.
I'm a physician on the faculty at Emory, and having spent a lot of time at Grady Hospital and also out in the community in some of the free clinics, I have tremendous respect for Morehouse's advocacy, because I think out of all the medical schools in the country, Morehouse is at the top rank there. But I just want to say, from a personal standpoint, the way I've been able to have an impact is like there was a girl, 23 years old, dying of Hodgkin's lymphoma, which was totally curable, and she worked in the cafeteria at Emory, didn't have insurance. So I went to the CEO of the hospital and just introduced her and said she'll be died in 6 months or less. She already left 50 pounds, lost 50 pounds. And you can save her life. And he did permit her to be treated for free at the hospital. We see in the newspapers pictures of people being shot on the street. We don't see in the newspapers, and we don't have any exposure to these people who suffer, who die early, and don't have to die early. And if there was some way to actually get those pictures of those faces up there, I think it could have a much bigger impact. Because even going to the state capitol, you talk to some legislator, they're totally removed from the personal experience of a young person dying when they don't have to die. And you know, in this country, the statistics are that we spend more on health care than any other country in the world, and yet our death rate is much higher than a lot of other countries. Do you think it's possible that Morehouse could actually take these stories and make them available on a website or something with the permission of family members? I think that could have more of an impact than just about anything.
Thank you for those comments. Anyone want to comment on that?
I think, oh, yeah, sorry. Well, I would suggest that not necessarily having them on the website would be the most effective way to communicate that, because if you're talking about at-risk population, then what's the likelihood of them visiting a Morehouse School of Medicine website? You know, so that may not be the best marketing strategy, but I definitely agree with you that it's getting this information to the public in a way that they can digest and appreciate and then become part of the solution. Absolutely.
It's just seeing the people, seeing the statistics versus seeing somebody who's going to die and doesn't have to die.
Certainly one of the advocacy strategies that we employ is developing strong relationships with media partners. So reaching out to Andy Miller at Georgia Health News and bringing it to his attention. He's usually very responsive, making relationships with AJC health reporters who I think have been, I think that may be a more effective strategy, but it's actually an interesting segue into the question I have. Just as a kind of a framing, I was given permission from the TCC project director to be provocative. So can we make that camera dysfunction for a minute? So my question is, politics today is very unforgiving. The legislature is very vindictive, particularly those in power. So perspective relative to Emory may be that Morehouse School of Medicine is very outspoken. I would actually argue the contrary and push my colleague, friend, and fellow advocate Daniel to say that in the public space we are way quieter than I would like us to be. And I'm often asked, which is an interesting position to be for a middle-aged white guy, why they're not hearing more of the kinds of things that I'm saying when I'm out there talking from other leaders at Morehouse School of Medicine around the devastating things that are happening on Capitol Hill, including today, where, you know, we talk about leading in the creation and advancement of health equity, but yet these horrific things are happening, and I think we are relatively quiet. So my question is, how do we navigate that space, understanding that there may be retribution in the way of a loss of the resources that we depend on? I think it's a relevant question, not only for you, Daniel, but it's a space that I know you have to navigate, Chanel. And I'm sure you, Pat, understand what that looks like through the organizations that you work with, in terms of how do we actively engage in advocacy and public discourse in a political environment where there is real retribution that can come to bear.
Yara, go ahead. I'll do the question now.
Yeah, so I think it's important to stay true and remember the mission and vision of your institution. And oftentimes, it takes form and shape in different ways. So being a graduate of the Satcher Health Leadership Institute Health Policy Leadership Fellowship, investing in the students that are here and educating them and making them aware about policy and health disparities, how to achieve health equity, and then those students going out into the world and being a force. So for example, in my role at the Tennessee Department of Health as the HIV/STD director, I've had the opportunity to address
sexual health disparities by making sure that our HIV surveillance data is inclusive of transgender populations. Making sure that we, across the state of Tennessee, are working with the disease intervention specialists who are seeing people face-to-face every day and asking them the appropriate and the right questions about sex at birth and your current gender. And then being able to quantify, our numbers around persons who are transgender and how many are HIV positive. In addition to that, syringe services programs will pass this year in Tennessee. And and I think that a lot of attention was brought to what happened in Scott County, Indiana, around a dual outbreak of HIV and hepatitis, looking at rural communities across our countries where we've invested our HIV resources in large urban areas, metropolitan areas, but looking at what's happening with the drug abuse, opioid use situation in our rural communities. And so nobody wants to be the next Scott County, Indiana across the country who's doing the work that we're doing in the HIV space. And so, being proactive and having syringe services programs in Tennessee. So I think we have to look at what the institution's mission and vision is and invest in the students who can then go out and be a force to address these things around the issues in health policy around disparities and achieving health equity. So I think that's important. The school, the institution may not be as vocal as some may want, but you're training people, you're training students who can go out and address these issues.
So, love the question, because I know exactly why you're asking it, and it's true. We can't get as involved as we'd like to, but I think to the gentleman's point before yours, that he recognizes just how incredible we've been in terms of leading this advancement of health equity in all public policy. So I would say that's fair. Nationally, I would say Morehouse School of Medicine is a leader in that right. But we can't be all things to all people. We have to be very selective with our battles. And I think you are right. We have to think about the consequences of every single advocacy effort. We're a nonprofit tax-exempt status entity. We'd be very foolish to try to fight IRS on this issue and try to go beyond legal bounds. So I'm always wary as a lawyer, making sure that we're very careful there. But what we do oftentimes is work behind the scenes. We work with coalitions, we work with alliances, associations across the nation on a host of issues to push forth this health equity agenda. Some things that directly impact the institution, we will absolutely speak up. So when we talk about the president's skinny budget, when you talk about reducing funding for the National Institute of Minority Health and Health Disparities, or the Agency for Healthcare Research and Quality, or the Office of Minority Health, wanting to eliminate it, we will fight and lead in that effort because we have been longtime champions of those. When it comes to Medicaid expansion, we understand, you know what, it would have a positive impact on our patients, but because of the bandwidth issue, again, we have to be very, very careful to, again, focus on what our policy priorities are, then working with those strategic partners that have the bandwidth that can continue to push that. So that is always my struggle, always the struggle of our president here at the institution. I think it's a struggle for all of us. But I think that's a fair question. Anybody else have an answer or thought about that?
I had some thoughts about successes that I've seen in terms of the autism spectrum, for example. I mean, the Marcus Center has done and continues to do really remarkable research to show that early intervention really can make a difference in a broad population of children. And this year, because I think of the work of the Marcus Center and the Emory Autism Center in educating people about how you can make a difference in pre-K, the governor put $65 million in the community health budget, and the plan for how that is being used is going to be left up to policymakers who are going to depend on the science that is developed by what you all do. The other thing I wanted to mention that I think we haven't talked about, and if you're in Georgia, you need to acknowledge the level of poverty. And one of the things that the governor did with looking at low-performing schools, it made it obvious that the research that is done by the scientists shows that it's not just bringing in a good teacher. There's a lot more that is involved in that community that keeps those kids from learning how to read by the 3rd grade. And out of that came some interest in what would you do in the school? You would have and because I worked in behavioral health, and we were trying to think about how to develop children's mental health services, and somehow it wasn't working that a mother had to take her child out of school and go to a doctor's office. They've talked about having, in many of these low-performing schools, some school-based health centers with a behavior intervention expert, and they really have put a lot of money in the budget to begin changing the school climate, so that if a kid is acting out, you don't send him home. You send him to talk to somebody who's at the school and helps the kid get back on track. We know kids can be helped if they're paid attention to and intervened with early on. So that's some places where I think the research has helped the policy move.
Excellent, thank you. So we have 2 more responses. We're going to take yours, and then I believe this, yes, this lady right here, and then we're going to have to close. So, yes, sir.
Yeah, so Reverend Martin Luther King died for his dream, and I wanted to know if Reverend Dr. Martin Luther King came back and asked each of you and gave you a grade for how much you are keeping his dream alive, what grade would he give you? And then I'd like to know, what would you ask him to help you do?
And say that last part again.
What would you ask Reverend Dr. Martin Luther King to help you get accomplished? That's what I'm asking.
Gotcha. Anybody else?
I remember the thing he said about the long arc of history. It's bending in the right direction, although we seem to be in a slump at the moment.
I think if he was to come back and give me a grade personally, I think he would give me an A. I am a health disparities case, so to speak, coming from a socioeconomically disadvantaged background, but not allowing those circumstances to stop me from being vocal and working towards something greater. And I'm very vocal. Anyone who knows me knows how vocal I am and how serious I am about the work of social justice and civil rights. So, I mean, I think one thing I would ask him to do is maybe take a mentee under his arm. Every revolution, it seems, needs a leader. And we're lacking in a leader right now, someone that people can rally behind. We have a lot of pockets of leadership, but I think that if we could rally around one person again, then we would probably have greater outcomes, or at least greater togetherness on the mission.
Thank you.
I think you had a question, right? Yeah. Oh, did you? So Jamie, do I have enough to do 2 more then?
Okay, we have enough for 2 more responses.
Okay.
And then I would like to also remind everybody that we actually have another opportunity for engagement this evening at our evening reception. For the sake of time, we cannot take every response, so please bear with us. I understand logistically it can be challenging, but we are trying to keep a coherent and a concise programming today. So there's plenty of time for conversation and engagement this evening, but we do have to bring a close to our session today. So please bear with us.
So specifically, I work with behavioral health, and I just want to also just engage the board in thinking about looking at fear as being an opportunity. We talked a lot about poverty, especially for Georgia. So how is it that we can utilize or I guess reduce the amount of fear that we have for individuals in order to speak up as it relates to mental health or behavioral health or health disparities as a whole. Because a lot of times, especially like you were saying earlier, in regards to getting your funding cut, if you do speak up, and speaking from the Morehouse perspective, then that's when you start losing funding for that. So how do you think we can work together in order to reduce that retaliation, reduce that fear, and increase the advocacy moment?
Great question.
I think Daniel gave an excellent example.
The partnerships. I think it's important to have strategic partnerships with coalitions, with associations, and work on a common agenda to advance health equity. So there may be spaces where Morehouse School of Medicine can't speak out or take a particular stance, but can work with another organization to support moving forward a particular agenda.
All right, last question.
Actually, I had a question here. I like to support what Mr. Dr. Hyman said in terms of, I'm an AUC graduate. I work with a lot of coalitions, Archie, I can name a lot more. My real concern is that the AUCs, which are predominantly African American, have not been supported by Morehouse School of Medicine like I know he was kind of pushing it. It's not a matter of, I don't think he's saying that you don't do a good job. But what the community and a lot of the organizations I'm working with are saying, you all have Morehouse School of Medicine, why aren't they doing more? So what can I say to those organizations when we come here and you're saying, well, we have to make a decision about what are we going to, this is our community, and a lot of other people don't want to come here and solve our problems. However, the resources are in our community. That's why other people won't come. So my question to you and any of the leadership at all of the AUC schools, the world is wondering how can we be the largest conglomeration of African American schools and organizations in the world, but yet all of our schools are in debt. We're probably not Morehouse School of Medicine, but the rest of the schools are in debt, and we need to figure out how to solve these health disparities because all of that is in relation to the conversation we're having today. So I'd like to know what is the real level of commitment that Morehouse School of Medicine has to the AU Center community, West End, Vine City, English Avenue, because there's other organizations who have a vested interest in it, and they don't do anything in the health disparities area.
I think it's a great point that we have to tackle. We obviously have the Satchel Health Leadership Institute, we have our Prevention Research Center, we do stuff with Tabia, Kintopia, and others, but I think there's a lot of things that are going on. We need to do a much better job in terms of promulgating that, communicating it, and then of course making sure that we're affirmatively reaching out to others in the AUC then and bring them on board and to talk about how we can tackle and increase community engagement. So I appreciate those comments. All right, last,
we have our last comment from the audience.
Last comment question.
Thank you. I don't have a question, but I do have comments. In terms of what grade would Dr. King give our Representative Gardner, he'd give her a VS, went in there from the very, very beginning, even to the point of attending our neighborhood association meetings, both she and her husband. And like she says, each time I reach out to her and ask her to wear purple, whether it's at the Capitol, when I was down speaking before the panel about House Bill 1, including epilepsy, to be one of the illnesses who would take the medicinal marijuana, and meeting with me each time down there. And just responding to an email, a phone call. If she can't do it, then her husband does. And anytime there's something going on in my community or anywhere in the city, I always send it to them so they know what's going on. So keeping them apprised of what's going on here at Morehouse is very key. If you can't do it, then you have your students to do it, and they will get it and accept it willingly. So adding that personal touch, and remember, it doesn't matter what your title, what your degree, so that we are all one. And I can truly say that Representative Gardner has embraced me from the very, very beginning. She saw no color, and for that I am truly grateful. So take an example from her. Thank you.
So politics is all about personal relationships. Unfortunately, it's more about personal relationships than facts. So you got to take your facts to one of your personal relationships, and that's how you can make a difference.
Very good. Well, with that last point, I think we're ready to go. Thanks, everyone.
Can we give one more round of applause for our moderator and panelists with our Policy Hot Topics Forum? All right. Yeah, we had some great conversation there, some great dialogue, and one thing I want to stress, the importance of us carrying on the conversation, okay? Don't let it end here in the auditorium of Morehouse School of Medicine. The goal of our TCC is to support the research and the discovery, translate that information into meaningful knowledge, and to disseminate that information to various stakeholders at multiple levels of influence. So this is our opportunity to kind of serve as a catalyst for that dissemination. So by all means, keep the conversations going, and by all means, join us for continuing the conversations later on in the other parts of our programming this evening. At this point in time, I would like to introduce to the podium Dr. Define.
When it comes in regards to our poster sessions, we had 12 submissions. And so our judges were able to identify 2 winners for our poster session competition. The first winner is, the title of their poster is No Longer Invisible, Qualitative Findings from a Father-Specific Evidence-Based Child Maltreatment Prevention Program called Safe Care, Dad to Kids. The author of this abstract is Clinton Boyd. He is a doctoral student at the Department of Sociology at Georgia State University. So, Mr. Boyd, would you please come up to receive your personal appreciation for your abstract? And Dr. Holden, if you don't mind to join our picture that we take. Thank you. Boyd was awarded $150 for his abstract. Our second winner, it's okay, Betty. Our second winner, the title of their abstract, Lyrics on My Mind, Recovery Dialogue Groups, Phyllis Tarver. Are you still here? Congratulations. You two have been awarded $150. You'll have to follow up with me after the conference, so we'll make sure, yeah, we're taken care of. Okay, you can come up to the stage, and we'll take a picture. Now for the moment everyone's been waiting for. Our first winner for the Shark Tank competition, our Dissemination Mechanism Award, will be awarded $7,500 to continue their project, the implementation of their project, by really focusing on the dissemination parts of their project. Our first winner is Linda Ellis with the Health Initiative Georgia's Voice for LGBTQ. The title of her project, the Georgia LGBTQ Health Collaborative. And I know Ms. Ellis had to leave, but we do have a representative from the organization here. Our second winner is Dr. Jen.
He's with the Whitney Young School of Social Work, Clark Atlanta University. His project is entitled Social Media-Based Dissemination of Health Information for Promoting Breast Cancer Screening Among Underserved Korean Americans. Dr. Jen had to step out. He wasn't feeling good, so we'll make sure that he gets his gift, his award, and we'll share the great news with him. So thank you.
All right, thank you all so much for joining us for the second annual TCC Health Policy Research Summit. This is health equity. So I think we all have some great fodder, we all have some great information, context, so when people ask that question, well, what is this thing that is health equity? Health equity is what we do. Health equity is what we are fighting for. Health equity is the path to eliminating health disparities. Let's be clear, there's a path, there are levels to this, okay? Health equity is community. Health equity is clinical practice. Health equity is basic science. Health equity are isms. Health equity is a process, and health equity is the goal. So I thank you all so much for being a part of this convening to have critical dialogue on health equity and how we can achieve health equity to ultimately eliminate health disparities in this country. I wouldn't be here without the support of an amazing group of individuals that have worked tirelessly on the preparations for the summit and the execution of all of the different components. So every year we try to do something a little different and also create a more robust opportunity to engage some of our community partners and have this be a true reflection of who we are. So I just want to thank all of you that were speakers and presenters and panelists, all of you that really made the richness of this program possible. Thank you so much, and I'd like to give you all collectively a round of applause. I would also like to extend thanks to our fearless leader, our founder, and our health equity pioneer, Dr. David Satcher. I would also like to extend so many thanks and appreciations for visionary leadership and focus and determination of our current principal investigator, Dr. Keisha Holden. Round of applause. Thank you, Dr. Holden, for always believing in me and believing in us. There are some other individuals. I'm really big on thanks because, again, it takes a village to do this kind of work, okay? So I think it's very important that we take the time and we take a pause to truly provide direct acknowledgments. You know I love you all, but there are specific people here that have gone above and beyond to make this experience comfortable for all of us. So I would like to give a special thanks to our
steering committee or our oversight committee. I know there are a few members of our oversight committee here in the audience. I want to thank you for your tireless commitment to our TCC for Health Disparities research over the past 5 years and the future of our TCC. Thank you so much for standing in the gap with us, opening doors, and allowing us to benefit from your sage wisdom. Thank you so much. I would also like to extend thanks to our community advisory boards who work directly with our sub-projects and our cores to enhance the reach and enhance the effectiveness of the research that we are supporting within our TCC. I have a special thanks to our host committee. That's who I call our tribe of very hardworking individuals here at Morehouse School of Medicine and the AUC community that have worked for many months to prepare this summit. Many tribes are led by great and visionary leaders, and our host committee leader is Dr. Divina Fabu, so I'd like to make a specific thank you to her. Your growth in leadership has been astounding over the past year and a half or so that we've been working together. And I just want to say thank you so much for what you do loudly and what you do quietly. My last thank yous are to our host committee team, Jada Bennett, Jeree Stroud, Deborah Jones, Kiana Washington, Klahe Buddy, Harriet Brown, and all of our dedicated volunteers that came out today. Give them a round of applause. At this time, I would like to conclude our second annual TCC Health Policy Research Summit. Again, thank you all for taking the time out of your busy schedule to join us and engage. We will be having our evening reception. We'll be meeting at the Ritz-Carlton Atlanta downtown at 7 p.m. We are all very excited to have you there if you can make it. If you need any instructions or any other information, you can go ahead and reach us outside in the atrium. And we do have a shuttle for our guests that are staying at the Ritz-Carlton Hotel, which will be leaving promptly at the conclusion of our summit. All right. Thank you all so much for your time and continue doing great work.
I'm sitting here, and if we could give one great round of applause for Dr. Hopkins. He has done a remarkable job over the last course of several months. So thank you, Dr. Hopkins.